Hi everyone, my name is Heather Watt. I'm an occupational therapist at a lymphedema clinic at Edmonton. At our clinic, we treat all non-cancer related lymphedema. Most of my experience is with primary and secondary lower extremity lymphedema. Today, I'm going to discuss some practical treatment plans for the client with complex lower extremity lymphedema. I have no financial disclosure or conflicts of interest with the material presented in this presentation. My objectives today are to discuss special considerations for successful treatment of complex lower extremity lymphedema, to provide practical treatment plans for this population, and hopefully encourage clinicians to think outside the box when managing these clients to help improve compliance and success. And I'll finish off with a few case studies. I want to start off with important things to consider of the client. It is important to know all comorbidities or factors that contribute to your client's lymphedema. This knowledge will help us create treatment plans that can target these factors to help limit their effects on the lymphatic system. For example, focusing on encouraging someone who is obese to manage their weight better, someone who is prone to cellulitis to perform better skin health, or someone who has mobility impairments to participate in exercise. Be sure to assess your clients physically and cognitively. Be aware of any physical limitations that may affect their ability to don compression garments or their ability to participate in exercise programs. Cognition also plays a factor. Are they able to learn new things? Can they problem solve effectively? How is their judgment? Plan to have supports in place early if needed. Consider your client's social history. Where are they from? Who are their support people? What are their daily responsibilities? How much time can they or are they willing to allot in their day to manage their lymphedema? What is their financial situation? Lymphedema treatment and management can be very expensive. And most importantly, consider their mental health. These clients often come to us with depression, anxiety, frustration, and self-esteem issues. How does this affect their motivation and readiness for treatment? Are they ready for a significant change in their daily routine to manage this condition? What are your clients' goals? What is important to them? What do they hope to achieve with treatment, and what do they feel they can manage long term? Ensure you and the client establish a treatment plan together. This will help with long-term compliance. Next, I'd like to discuss some important things to consider on the clinician side. Of course, educating yourself on lymphedema and lymphedema treatment is always good. It's important to learn about all the different types of compression garments out there and how to appropriately prescribe them. New products are being developed so frequently, this can be very overwhelming. Work closely with your garment fitters to choose and evaluate garments. We need to ensure that we are educating our clients appropriately. Some need more, some need less. Education can be very powerful in improving our clients' motivation to follow through with treatment programs. Teach them not only what is recommended, but why. Be creative. There is no recipe that fits all clients. Think outside the box. Don't be afraid to try new things. Compromise. This is a tough one, but it is important for our clients to be successful and compliant. There is no treatment plan that works for everybody. Okay, let's start talking about treatment options for the reduction phase. I'm going to run through three main compression options that we offer our clients. First and most popular is the 2-layer compression wrap. This very effective wrap is usually applied by a health professional, so clients must be able to attend clinic at least 2 times a week. This wrap is quite simple to apply, it's versatile, and there are many modifications that can be made to improve its success. This option requires little effort on the client's part. They just have to tolerate it, attend clinic twice a week, and keep it dry while showering. The second option is multi-layer bandaging. As you may know, this bandage is reusable and needs to be reapplied 1 to 2 times per day. For this reason, we only offer this option to clients who are able to bandage themselves, as we are unable to see them daily. Biggest thing to consider is that it is very time consuming for the client. It's very bulky and can affect mobility and the fit of clothing. Clients also need to have adequate physical and cognitive ability to safely use it. The last option we've been using a bit more frequently is reduction garments. These garments are secured by Velcro and can be trimmed down as the limb size decreases. There are many considerations that need to be taken before choosing this garment. It is not for everyone. Depending on the severity of edema, it can be more cost effective than the 2-layer compression bandage. It requires less clinic time and is physically less challenging for the clinician. Again, the client must be cognitively and physically able to apply the garment or have a support person to apply it for them on a daily basis. It's always good to start talking about the long-term compression plan right from the start. Consider the cost, client's time, their activity level. Highly active clients will require higher compression levels. Consider the stiffness of the material you're prescribing. Well, they need nighttime compression. If their edema fluctuates, compression tools that the client can use to reduce edema themselves are essential. The more options and tools the client has, the better self-managers they will be. There are many different types of garments and combinations of garments used during the day and or night to consider. Get familiar with options available to your clients. Consider multi-piece garments. For thigh-high compression, a knee-high and thigh legging is easier to don and tends to stay up better than a one-piece thigh-high. Adding a hip attachment to a thigh-high can help the garment stay up better. Foot gloves and compression anklets are great options for tough to manage feet and ankles. Also know all the bells and whistles that can be added to a custom garment. Liners at joints to improve comfort, or pockets and pads to improve control in challenging areas like the ankle and dorsum of the foot. When we need more than just stockings, we look at the use of other options to either wear at night or during the day. Multi-layer bandaging and adjustable Velcro compression systems are great options, as not only can they be used at night to control edema, but in a flare-up, they can be used to reduce edema instead of the client having to return to the clinic for more treatment. For more mild cases and a less expensive option, a flat knit stocking, tubey grip, or edema wear can be considered for nighttime. Pneumatic compression pumps are also another tool that can be used, but can be quite expensive. I read an article recently a while ago that included a transition phase in the treatment of lymphedema. I thought this was brilliant. I find this is the most complicated and difficult part of the lymphedema treatment. This is a time our clients truly need the most support. We are usually transitioning from doing most of the work for them to them being in charge of their treatment plan and being independent managers of their edema. It's a big change. During this time, we need to evaluate and assess our plan, ensure the garments we have chosen are actually working. We don't always get it right the first time. We need to be checking in with our clients to ensure they are managing their new routine, proper garment donning, proper care of the garments, continued skincare and exercise. The client might have some difficulties, unexpected difficulties. Many things could go wrong. Adjustments to treatment plan and further compromise will be required. When you reach the maintenance phase, clients should be managing their lymphedema independently with or without their support people. They are completing a daily routine that includes compression, skincare, exercise, and are striving for a healthy lifestyle. Most importantly, we need to ensure continued long-term follow-up. Symptoms can worsen and adjustments to treatment plans may be required over time. I'm going to discuss a few case studies with you to show you how we've been creative with some of our clients. These case studies are real stories, the pictures are not. I was unfortunately not able to use the real client pictures for this presentation. So Braden is a 45-year-old male with severe lower extremity lymphedema in the left leg. His skin texture is almost non-pitting. We did observe mild pitting in the left thigh. He had no history of infection or wounds. He is moderately overweight and has no significant mobility problems. Braden works shift work as an equipment operator. He is sitting most of the day and in a very confined space. He has family and lives in a small community about 5 hours north of the closest lymphedema clinic. This client has never had treatment and he does not want this to consume his life. He wants the easiest solution possible. We started with education on skincare and importance of weight management. The exercise plan was a tough one. He was able to complete the regular exercise routine before and after work, but the problem was he had to sit all day. We encouraged frequent ankle pump exercises and sitting, and any chance he had, he got out of his machine and stood, even if it was just a minute or two. He was not able to attend the lymphedema clinic for treatment, not only due to travel, but his work schedule would not allow it. He did not want to commit to wearing a thigh-high compression garment, so we decided to treat to the knee and closely monitor the thigh. This is a compromise we make with many of our clients. He reduced the edema himself with a Velcro compression reduction garment and eventually progressed to a high pressure compression class 3, custom knee high, flat knit, and he used a Velcro compression system at night. He managed edema well with this plan for a few years until his left thigh actually started to increase. He still was not willing to wear thigh-high compression daily, so we taught him to bandage his thigh with a multi-layer bandage, which he applied at night. This helped the edema from progressing and prevented some skin changes. This is the best part. After a couple years, the client returned and had lost over 100 pounds. He no longer had pitting edema in his thigh and was able to manage his lower leg edema with a compression stocking daily and only occasional use of his nighttime compression garment. I have many stories like this. Weight loss has a significant impact on edema. Our clients need to know this, and we need to support them with this the best we can. Be aware of your local weight management programs and consider taking a weight management course for health professionals for support on dealing with this often very difficult and sensitive health problem. Next case study is Chris. He has lymphedema, likely secondary to obesity, decreased mobility, and recurring wounds and infections. It's thigh high with significant changes in the thighs, and bulk of edema is greatly affecting his mobility. He was quite sedentary, he wasn't working, he spent a lot of time sitting and gaming. We provided significant education emphasizing the importance of good hygiene, skincare, weight management, and exercise. We treated him bilaterally to the thigh with a 2-layer compression system and completed wound care with the help of our nursing friends. We first trialed a 1-piece thigh-high compression garment. I chose the compression class 2, thinking it might be easier to don, even though the severity of his edema would indicate a compression class 3. Unfortunately, he was not able to don it independently, which was quite important to him. We had success in a compression class 3 custom flat knit knee-high with a thigh Velcro system, which overlapped the knee high just a little bit. It took some time to get used to, as the thigh garment required frequent adjustments during the day. We modified it with some old stocking material and added a hip attachment to help it stay up. This client also uses a full leg Velcro compression system at night and is managing very well. Tracy has lymphedema secondary to obesity, previous trauma from a motor vehicle accident and decreased mobility. She presents with lymphedema in her lower legs and thigh. It is also present in her pannus, which hangs quite low and also impairs her mobility. She had significant skin impairment on her lower legs, putting her at high risk of wounds and infections. The skin on her thighs was becoming more fibrotic, but still fairly healthy. She lives independently and understands that she will likely require help with her long-term compression garments. We spent a lot of time providing education to this client. We discussed her weight and the impact it has on her edema and the difficulty that people have maintaining edema reduction when at an unhealthy weight. She had recently started working with a dietitian and was very motivated to work on weight loss. We also discussed the risks of compression treatment, including pushing more edema into her thighs and even worse into her pannus. Abdomens are very difficult to treat. I have never found an effective garment, as most clients do not tolerate the compression, so we really can't risk increasing the edema here. With all this in mind, we decided to only treat her edema to her knees and only reduce the edema until her skin health improved on the lower legs. Reducing to a complete dry state will only push more fluid into the thighs and pannus and make it more difficult to maintain the reduction long term. Once reduced, this client will progress to a custom flat knit knee high at a compression class 3 and a Velcro compression system at night. We will have to closely monitor her thighs and abdomen over time and treat as necessary. We also suggested a couple of weight management programs that she may benefit from. Hopefully with success with weight loss, she will not require treatment to her thighs or we can treat her thighs without the risk of increased edema in her pannus and a greater chance of being successful with edema maintenance. That's all I have for you today. Thank you so much for listening. I hope you enjoy the rest of the conference.
Hello, my name is Shelley DiCecco, and I'm a lymphedema therapist in the United States. I happen to specialize in genital lymphedema, so I was asked to speak today on some creative management solutions. My goal with this presentation is to hopefully reduce your anxiety as a healthcare practitioner with treating this patient population by giving you some ideas for objective assessments, compression, and MLD. It is key that as part of your new patient intake forms, you include a genital-specific questionnaire or quality of life tool. This opens the communication between you and the patient on this sensitive topic and can provide you insight into things you need to assess more deeply in the evaluation portion. That I had the pleasure of assisting Rhiannon Noble-Jones on developing these two particular tools, the lower limb and genital lymphedema questionnaire for both males and females. You can download these for free at my company's website, lymphed.com/edema tool. Patients found that when they were using tools like this, when things are already typed out, it helps them realize that others have the same symptoms. And then it also helps the practitioner with where to kind of begin with what they need to assess. It is important during your objective assessment that you are palpating the bony prominences on your patients. For these will aid in helping you properly identify your lymphatomes and assessment of the vital muscles in this region that should be incorporated into your treatment. The key ones I find are the iliac crest, the ASIS and PSIS, the pubic bone, the pubic symphysis, the ischial tuberosity, the pubic rami, sacrum, and coccyx. If you can find these structures on your patients, you can identify the borders of your lymphatomes and help distinguish where the origin and insertion of your muscles are. There are over 46 muscles that either originate or insert on some portion of this bony pelvis. As healthcare professionals, we should be assessing these muscles for muscle length and for strength. These muscles should play a vital role in the reduction of the fluid with your CDT treatment. Too often, the muscles that are attached at the bottom portion of the pelvis, the pelvic floor muscles, are overlooked. These, along with your transverse abdominis, are the most important muscles for core stability and for lymphatic drainage of the genitals and the lower extremities. A contraction of these muscles, particularly the pubococcygeus portion of the levator ani, is called a Kegel. And as you can see from here, the bony landmarks are still marked with blue stars. Here you can see how the pelvic floor muscles are intricately involved with your lymphatic system. You can also see how the lymphatics are bordering up to your abdominal muscles and just anterior to your back muscles. As other portions of your objective testing, for visual inspection, you need to locate where is the edema. Is it just in the genitals, just in the trunk? Is it on one side more than the other side? What's the condition of the area? Is there any discharge? If so, is it clear? Is it lymphuria? Is it chylous? Is it something related to some type of infection? Are there actual genital warts or is it papillomas? Do you see any signs of infection, distortion of shape, or other skin or tissue changes? You need to see, is there a pannus? Is it going to be providing additional stress onto the genitals and the inguinal lymph nodes? Along with visual inspection, palpation should also include the trunk and the genitals. You need to palpate the anterior and the posterior trunk, including the buttocks and the genital region. You need to assess the skin and the tissue's mobility and texture just as you would on an arm or an upper trunk. You can palpate externally to see if there's fluid accumulation internally. You should only be doing an internal assessment for palpation or tissue if you are a pelvic floor therapist or healthcare professional that has been trained in doing internal assessments. I find the best place to check for pitting is just distal to the transverse perineal muscles near the rectum. To find this place, you would first have your patient in hook line. They can have their underwear on to help with the ease for both patient and therapist in this region. First, you would need to locate the ischial tuberosity. It is where the hamstrings attach, and you can find it by sliding down the back of the thigh. Next, you're going to move your finger over medially 1 to 2 inches, just off the gluteal and thigh fold into the area just lateral to the anus. Then you're going to move your finger anteriorly so that you're above the anus, lateral to either the scrotum or the labias, and you're just medial to the adductors. Right above your finger should be the transverse perineal muscle. In this region, you can feel the tissue kind of sinks in, and is a great place to check for pitting to see if you may already have some internal involvement and are at risk for either developing genital edema or worsening of genital edema. Girth measurements are also important, but they can be tricky with the genitals. You need to be able to capture the true involvement and be able to remeasure in the future. I recommend looking for bony landmarks, like discussed previously, and scars or birthmarks. You can document the distance from these and the areas of interest with your measuring tape. You can also capture the circumference and the length of the genitals. These are some images of just a few places that I frequently use while in the clinic. Going across the pubic bone, going around the scrotum, you can do circumferential, both anterior to posterior and inferior to superior. The length of the labias, the length of the penis, the width of the labias. Do make sure you are going all the way to the internal portion of the labias, not just where you feel comfortable touching. So they do need to open up some. And the circumference of the penis, and then also the distance from the anus to the ischial tuberosity will help capture some of the posterior edema or gluteal areas. Once you've done your formal assessment, now we need to figure out how are we going to provide compression for this region. The key with compression is whatever will stay is what is key, that it's got to hold. And the patient has to be able to change it regularly for hygiene. They need to be able to use the bathroom. They need to be able to clean it. And if there's a lot of moisture because of this location, they're going to need to change it to dry material. You and the patient also need to be ready to change the technique often, for as the shape changes, what stays in place will also change. Your key component is the bandage also has to support the genitals to fight against the pull of gravity. If this can't be accomplished by the bandage itself, then they will need a supporting compression garment or something on top to help lift up. For garments in general, it does need to be breathable. This isn't as big a concern with bandaging because most of the materials we use are breathable, but with your garments, they're not always as breathable as they need to be. This is a warm, moist environment, which is a perfect breeding ground for infections. Again, the day garment must support against gravity. At night, when the patient is horizontal and not worried about what others can see, that is the best time to really address the edema accumulation of the day. So the night needs to be more reductive in nature. Typically, at least the day garment will need to be custom, for the painty portion generally does not have compression with your off-the-shelf garments. There are 4 materials I typically use when bandaging males. The elastic gauze is the cheapest to use. The elastic gauze and the medium stretch bandages do provide adequate compression. They just can be cumbersome to don evenly and frequently, that they can slide off if you're not pulling at the right angles, and it's common to get more of the bandage on the superior portions than on the inferior or side portions, which would push the edema the wrong direction. The males do need to get this on in a timely manner when they're going to the restroom, so this can sometimes be troublesome for them. The foam bandage is easy to don and adjust frequently during the day. It can also be washed and reused multiple times. The cost bandage, though, is significantly higher than using either the elastic gauze or the medium stretch. Coban 2 Light is a great system, especially when the patient is safe to wear it for an extended period of time. If your patient can go more than a day in the garment or the bandage, you can use Coban 2 Light. The problem is, of the 4, this is the most expensive garment or bandage to use. Female compression is more difficult. One, you can bandage the genitals. You need to make sure it has a thigh component. This can hinder ambulation and hygiene. I typically use a foam insert, pre-made, or one I fabricate, and then use neoprene straps to provide the proper compression. This is easy to don and doff for hygiene. This particular patient is also wearing a neoprene thigh piece to help support where she likes to bulge out on the lateral thigh. I do address the thigh and trunk for majority of my patients. You can see with this one that she has the medium stretch going from the thigh up into her trunk on both sides. Biker shorts or trunk compression are also very important to help with the lower trunk and thigh areas. You need to work with the patient to find what works best. The pictures on the red are other genital supports. The top one is of male support garments, and the bottom is of female support garments that you may need to use. Keep in mind with the patients, keep telling them and yourself that sometimes it takes a lot of tries to find what works best for that patient. You may also want to use foam inserts with compression garments and or bandaging, and these are several of the different pre-made ones that are out there. You can also buy bike pads inserts and use those inside garments or bandaging. For MLD, you must address the lower trunk and the genital portions prior to going to the lower extremities. You do need to make sure, even with lower extremity lymphedema, that you're still addressing the trunk. For if you don't clean these areas, the fluid can back down into the genitals. If you're not comfortable working on the genital portion of a patient, please refer this person on to a therapist that is comfortable with it, as opposed to ignoring it and thinking it will go away. You also need to make sure when you're treating legs and or genital involvement that you are checking the spot we talked about earlier to see if it is progressing into an internal portion. This is my typical MLD sequence for my patients with genital involvement. I address as many nodes as possible to assist in drainage. I also have my patients doing several types of truncal breathing, thoracic, diaphragmatic, and abdominal breathing to help incorporate muscles and movement of the fluid. I pull in the pelvic floor muscles and the transverse abdominis muscle, along with your other gluteals, back and core muscles, to also assist in the movement of fluid. There are two main pathways that you can use for MLD when genitals are involved, and those are the anterior and posterior pathways. Remember, for the trunk, anteriorly, the pubic bone is the demarcation line between the inferior trunk lymphotome and the pubic or medial thigh lymphotome. The genitals are part of the medial thigh. So I would go from the inferior trunk into the superior trunk. I would have cleaned it above in the superior trunk previously. I would take the medial thigh up over the pubic bone into the inferior trunk, and then bring the genitals up and over the pubic bone into the inferior trunk, eventually to the superior trunk. The path that I particularly use the most with my patients is the posterior pathway. I clear the inferior trunk into the superior trunk, the lateral thigh into the inferior posterior trunk, the medial posterior buttocks area over into the lateral thigh. Then the genitals are coming up from the posterior portion into the medial buttocks, over laterally and up. Or you can actually just go straight from the medial up by the PSIS straight into the inferior trunk. I find because you're not going across the pubic symphysis and mons pubis area, which are laden with adipose tissue, that actually the posterior pathway typically clears out for both males and females much faster and easier than going anteriorly. And lastly, Rhiann Noble-Jones and I are doing a survey study on how confident therapists are on treating and evaluating genital lymphedema. We would appreciate it if you would take a few minutes sometime in the future and answer the survey for us so that we can make sure we're capturing as many therapists internationally as possible. I am sorry that I have gone so fast through all of this, but I wanted to make sure I could cover as much as possible in the time that I was allotted. I thank you for taking the time to listen to this, and I will be available for the question and answer panel later. Thank you.